starting with a general examination while looking at the patient to see if patient is diaphoretic or pale or under any acute distress. There is also no use of any accessory muscles. Looking at the patient's eyes, the spacing is normal, with no yellow patches of cholesterol deposits on the eyelids suggestive of hyperlipidemia. With the pen light, looking at the conjunctiva, and it is pink. If it was pallor, that would indicate anemia. There is also no lens displacement, indicative of Marfan's syndrome. Using the pen light on the tongue and lips, checking for central cyanosis, any discoloration would indicate right heart shunting. I also look at the finger's tip of the nose and earlobes for signs of peripheral cyanosis. Using the dorsum of my hand, I move upwards on the body, feeling for temperature and looking at the skin for any signs of erythema marginatum. Also looking at the extensor tendons of the fingers, there are no signs of palmar tendon xanthomas indicative of hypercholesterolemia. Now looking at the palms and fingers for signs of osseous nodes or Janeway lesions. Looking at the fingers for splinter hemorrhages indicative of infective endocarditis. Placing two thumbs together to look for signs of clubbing. Now placing my hands on the tibia for 5 seconds, we are checking for signs of peripheral edema, which would be indicative of a deepening of the skin. To determine the pulse, we will palpate the radial pulse on both arms. In doing so, we will conduct this for 1 minute. Looking for a normal rate and regular rhythm as well as a strong pulse of 2+, and making sure the pulse is symmetrical. Also noting the patient's respiratory rate at the same time. Having the patient sit down in an upright position, we will make sure that the bladder of the cuff is centered over the brachial artery. Placing 2 fingers on the radial artery and inflating the cuff until I no longer feel the pulse. When doing so, we are determining the baseline. Placing the stethoscope with the bell, we will inflate the cuff 30 mm of mercury above the baseline. With the stethoscope, we are listening for the Korsakoff sounds. The first Korsakoff sound marks systolic. The disappearance of the sound marks the second Korsakoff sound will mark the diastolic pressure. Having the patient at a 30-degree angle. I will auscultate the carotid artery by using the diaphragm and then the bell, listening for any brutes. Any turbulent flow would indicate brutes were present. Since no brute is present, I apply pressure until I feel the maximal pulsation with 2 fingers. There are no feelings of thrills. The amplitude of the pulse is a normal and strong. The contour is normal, where upstroke is smooth, rapid, and brisk. The peak is smooth and rounded with a gradual downstroke. With the patient lying flat and their head to the left, I will examine the internal and external jugular veins. The internal vein is medial and the external vein is placed laterally. To confirm, when pressing on the vein, I shouldn't feel a pulse. Now, I will focus on the IJV pulsations and look for the highest oscillation point. The oscillation point is where the external jugular vein appears to collapse. Now I will slide 5 centimeters down from the jugular notch to the sternal angle and place my ruler there horizontally at the sternal angle. Then I place my note card at the point of highest oscillation point. With this, it records to 3 centimeters of water above the sternal angle. Now, I am adding 5 centimeters equally to 8 centimeters of water above the right atrium. We are adding 5 centimeters because the right atrium lies 5 centimeters below. Normal JVP would be 1 to 4 centimeters above the sternal angle or 8 to 9.5 centimeters of H20 above the right atrium. Asking the patient to breathe through their mouth quietly, I will place my hand on the right upper quadrant of the abdomen just below the rib cage and exert firm pressure for about 30 seconds. Normally, the JVP would rise but then return to normal. Now inspecting the precordium, there are no scars which would indicate a pacemaker implant or previous cardiac surgery. No signs of pectus excavatum and no pectus carinatum, which would indicate Marfan's syndrome. Bending down to the patient's body level, there are no visible pulsations, heaves, lifts. There are no chest wall retractions, which would be indicative of constrictive pericarditis. Starting at the jugular notch, with 1 finger, I slide down the sternal angle. Sliding to the left to the second rib. Then counting down to the 5th intercostal space, I will use my index finger to feel for the apical pulse. When doing so, I will ask the patient to lay on their left lateral side and continue to feel for it. When feeling for it, I will take my pen and draw a circle around it. Then I will measure it. Normal findings are that the diameter is less than 2.5 centimeters, the amplitude is small and feels like a brisk and gentle tapping. Now I auscultate the PMI and palpate the carotid artery at the same time. The apical impulse is felt in the first 2/3 of systole and coincides with the S1 sound. Therefore, S1 coincides with the carotid pulse, and the impulse occurs in the first 2/3 of systole. Now feeling for thrills, heaves, lifts, and pulsations. Thrills are felt with the ball of the hand, heaves are felt with the finger pads, and pulsations are felt with the palm of the hand. Starting at the PMI, I am going to feel for heaves. Then moving up and checking the second, third, and fourth intercostal spaces. Starting at the jugular notch, sliding down 5 centimeters to the sternal angle, move laterally to the second rib. I then start percussing down to the 6th intercostal. At the 2nd intercostal, it is resonant. At the 3rd intercostal, it is a transition. At 4th and 5th intercostal, there is cardiac dullness. At the 6th intercostal, it is tympanic because it is the fundus of the stomach. At a supine position, I start off with auscultating the PMI. With the diaphragm, this is where S1 sounds are best heard. At the tricuspid area with the diaphragm, S2 sounds are heard louder than S1. At Erb's point, S2, S3, and S4 sounds are best heard. At the pulmonic area on inspiration, physiological splitting occurs, where A2 precedes P2. At the aortic area with the diaphragm, signs of aortic regurgitation can be heard. With the bell, aortic stenosis can be heard. Now I have the patient sit up. With the bell, I auscultate the PMI. Having the patient leaning forward, exhaling and holding their breath, listening for Austin Flint's murmur, then with the diaphragm, I will listen at the 3rd intercostal space at Erb's point where chronic aortic regurgitation can be heard. Then I will ask the patient to lean forward to enhance the diastolic murmur.